Good afternoon, everybody, and thank you for joining us at the BHF Annual Conference 2021. I'm Kent Woods, the Deputy Chairman of the BHF Board of Trustees. We have a full and interesting programme for this Zoom webinar, and I'm delighted to see that so many of you have been able to join us. The past year or more has been like no other in the 60-year history of the Foundation. It's presented major challenges for the organisation, for the research community it supports, and for the population we all serve. It's important to reflect on what we've learned during the pandemic and on the forward view from here. The meeting is in 4 parts. Firstly, we will look at our response as an organisation to protect our research mission and to support patients with cardiovascular disease. Secondly, we have 3 distinguished speakers to review what we know of the clinical impact of COVID-19 on cardiovascular health. We then have as our guest speaker, the Chief Medical Officer, Professor Chris Whitty, to give us his reflections on the COVID-19 pandemic with a Q&A session. And finally, there will be a panel discussion, again with distinguished invited speakers, to consider the future with regard to COVID-19 and cardiovascular disease. There'll be a brief comfort break between the second and the third of these elements. Now, a few housekeeping details. Your microphones and cameras have been turned off in view of the numbers on the conference. We think we have about 300. As I've mentioned, there will be a Q&A session at various points in the programme, and you're invited to post your questions in the Q&A function of Zoom. And I will alternate the chairing with our Medical Director, Nilesh Samani, when we get to the Q&A. The conference is being recorded, except for the CMO's talk. That is under Chatham House rules. Views expressed in the meeting can be shared, but they must not be attributed to any individual directly or indirectly. The purpose of this is to allow for a candid discussion. We'll be sharing content through the day using #BHF Conference, and you're welcome to use that, subject of course to the Chatham House rule. Now on to the main business. I would like to welcome as our first speaker, the Chief Executive of the BHF, Dr. Charmaine Griffiths. Charmaine took up her post in February and had an extremely robust introduction to the role of CEO as the pandemic hit almost immediately. She is therefore going to talk to us about the work that the Foundation has done to protect its research mission. Charmaine.
Oh, thank you, Kent, for your kind words. And I'm just delighted to welcome so many friends of the British Heart Foundation to join us today for such a fantastic programme at a really key moment in our 60-year history. It was, as Kent says, my privilege to rejoin the British Heart Foundation as Chief Executive in February 2020. And I think it's quite staggering to process how significantly the pandemic has impacted almost every aspect of our world since then. There's no doubt that the pandemic remains the biggest challenge that the British Heart Foundation has ever faced, and today is a really important time to come together at our annual conference to share intelligence on COVID-19 and cardiovascular health, and also to reflect on the journey that we face ahead together. So I want to start the conference by sharing and taking a few moments to share with you the journey that the British Heart Foundation has been on over the past year and the exceptional efforts of our BHF team to protect our life-saving work. So I'd like to start by asking you to cast your minds back to last year and just to recap on the impact of the pandemic. Firstly, as you'll hear from so many of our speakers today, it became clear really early on that people with heart and circulatory disease were more at risk of serious illness and death, it being an underlying condition cited on 45% of death certificates. Secondly, we also started to see really early on impact on people with other heart and circulatory disease conditions. People who were experiencing heart attacks and strokes were not seeking the help that they needed when absolutely every second counts. And we started to see the growing backlog and disruption in treatment and care for people. And operationally, there's no doubt it had an enormous impact on us as a British Heart Foundation. Over 60 years, the BHF has established an organisation that's formed of 4,000 brilliant colleagues, 18,000 volunteers, based in shops, stores and sites across the UK's 4 nations. And overnight, we had to close our doors to shoppers, cancel much loved fundraising events and activities, and learn to work remotely as a team. And we anticipated even then that the impact on us financially would be profound, halving our net income and impacting our ability to fund new research. So what did we do? Well, we actually looked to our strategy, of course, to 2030, and they say in a crisis that things that matter to you most become clear, and they certainly did for us as a BHF. It was really clear to us that 4 simple priorities would be our guiding cornerstones through this pandemic. And actually we set them, and I'll share them with you now, and they're pretty much as true today as they were then. The first is to be there for the people who matter most, and that's the 7.6 million people living with heart and circulatory disease across the UK's 4 nations today. The second was do everything we can as the leading independent funder of cardiovascular research in the UK to protect our research core and the talent and programmes and projects we know drive progress. And to do that, we knew that we would have to protect our income and our financial sustainability, and also, and by no means least, protect our people through profound impacts on their personal and professional lives. So today you're going to hear quite a lot about what we did from other speakers and the impact we've had that we're deeply proud of, but I'd like to share with you a few headlines. So looking to people with heart and circulatory disease, my colleague Sonya, our Associate Medical Director, will expand on this, but we're deeply proud of the way that the team responded. At speed, our team mobilised our heart helpline to meet the surge in demand of queries and from people needing support information, and also set up a brilliant coronavirus hub that has since supported 6 million visitors with information and support is updated and trusted regularly. We've also been active in campaigning to help encourage people who have heart attack symptoms to seek the help they need when every second counts, and also to tackle the backlog of treatment and care that people face. And it's not just our support for people that we're really deeply proud of. We've actually played a key role as an organisation in the research response to the pandemic. You'll be hearing from Keith Channon shortly about how we rapidly mobilised leaders from our BHF Data Science Centre, the National Institute of Health Research and the British Cardiovascular Society through our pioneering NIHR-BHF Partnership to actually fund 7 COVID-19 flagship programmes, really looking at the basis of the connection between COVID-19 and cardiovascular disease. We're also really proud to have supported both our researchers and colleagues who volunteered to return to the NHS frontline and play their part in supporting people who needed them. And lastly, but by no means least, we did everything we could to be flexible by granting extensions, and particularly for our PhD students and projects close to the end, that there are a risk of disruption from COVID-19. And we did this knowing that we need to protect the progress within those programs and projects that make all the difference for people with heart and circulatory disease. And we know also that we have much to protect. For 60 years, we've been a leading funder of cardiovascular research and are the leading independent funder today, funding over 55% of all independent cardiovascular research. And we fund so much. I mean, our current commitment is around £446 million of current activities. And that includes supporting 1,500 brilliant clinicians and researchers and many more beyond, and over 900 projects at institutions across the UK. And there's no doubt last year that we've seen the sharp impact of the pandemic, and with all other research funding charities, seen a cliff edge in funding available for medical research. I shared with you a few moments ago, we anticipated our net income dropping by around 50% and having a knock-on impact on our new research funding of about the same proportion. So I'm really proud that we've stood in solidarity with 150 other charities and the Association of Medical Research Charities to lobby government to request funding through a Life Sciences Charity Partnership Fund to help mitigate the impact of that cliff edge in funding so that it doesn't damage our talent and our programmes and projects. And we're yet to see the results of that, so I'll come back to that in a moment. I also want to acknowledge for a moment we had to make some tough strategic choices as a BHF last year. In the face of that unprecedented disruption, we took the decision to resize the organisation and enhance our focus on research as a BHF. We know that wasn't easy, but it has put us in a strong position as we enter our 60th year and of course face the uncertainty ahead. So today we are, as we like to describe ourselves, 60-year young this year, and we are as determined and as passionate as we have ever been as a BHF to make a difference in our work to beat heart rate forever. We know we've made tough strategic choices, but we also know now we're in a robust position. Of course, like you and your organisations, we face uncertainty and volatility, but we've got a clear plan, a brilliant team, and a clear focus about how we're going to work through this. I'm really proud that we were able to keep our doors open for new research last year when many others could not. And in fact, despite the financial impact of the pandemic and having to close our retail estate for nearly 8 months out of 12, we're able to award £52 million of new research in 2021. And we're working really hard as a brilliant BHF family and team to recover our ability to keep that going and recover that back up to historic levels and hopefully beyond. So I want to finish the opening by saying thank you, actually, a few thank yous for people. Firstly, to our incredible BHF team. We have the most amazing volunteers, colleagues and supporters, and everybody has risen to meet the challenges we've faced, and their drive and their innovation and their spirit never fails to inspire. I also want to take a moment to thank our partner organisations and collaborators, many of whom I know are with us today, for rallying around us and offering your support, advice and funding. It's been phenomenal. And lastly, to our healthcare professionals and researchers, of whom there are of course so many to hear today, I just want to say a huge thank you on behalf of our BHF team for continuing your vital work, for returning to the front line, for fundraising for us, for lobbying for us and standing alongside us. It makes an enormous difference to us as a BHF team. And in our 6th decade as a BHF, it has simply never been more needed. So thank you. Thank you, Kent.
Thank you, Charmaine. That was a great overview, and we'll explore further some aspects of the work you've been covering. Thank you very much. I hope you can hear me. I'm having some trouble starting my video. There you go. Right. Thank you very much for that, Charmaine. I will get the technology fully mastered in the next moment or two. I would like to thank you for giving an overview of many of the topics that we're going to be covering in the next coming minutes. As you said, that there are over 7 million people in the UK living with heart and circulatory disease. And for many of them, the pandemic has been a particularly difficult time. I would now like to introduce as our second speaker, Dr. Sonya Babu-Narayan, who is the Associate Medical Director covering this area at the BHF. And she's going to describe what the Foundation has been doing to support cardiovascular patients during the pandemic through its patient first response. Sonya.
Thank you, Kent. I'm here to tell you about how the BHF are saving lives with campaigns and reaching millions of people with support. People living with heart and circulatory disease are at the center of the pandemic's impact. They've been hit by a double blow, being at risk for severe COVID-19 illness and death, but also at risk of having their heart disease going untreated. Some COVID-19 patients have also been newly diagnosed with heart disease. Health inequalities, already so driven by heart and circulatory diseases and their risk factors, have been exacerbated by the pandemic. Disparities in the treatment of heart attack linked to sex and ethnicity only became worse. An immediate concern for us was that people might not seek help in the way that they normally would or should. Cardiologists told us that fewer people were attending hospital for emergency treatment of a heart attack, which you'll hear more about from BHF Professor Barbara Casadei. Patients were frightened of coronavirus or worried about putting pressure on the NHS and so they didn't seek help, despite that the NHS has always been open for emergencies, including heart attack and stroke. We launched a campaign to urge people to call 999 if they thought they were having a heart attack, working with NHS England, the British Cardiovascular Society, and BHF-funded researchers. Over the course of the campaign, 350 media pieces reached 7 out of 10 adults in the UK with this message. Heart attacks are more likely to kill you than getting COVID-19 in hospital and dying of it. And thanks to decades of research, they can be treated effectively. Getting this message across saves lives. But there was an ongoing need for further information and support. At speed, our heart helpline service was scaled up to meet an immediate surge in demand, and its hours were extended. More than 1 year on, there is still a 38% increase in contacts from people affected by heart and circulatory disease, with a newly increased traffic of email queries. COVID-19 was, of course, a new disease with evidence emerging all the time and opinion and guideline from various sources. The public looked to BHF for trustworthy, reliable, clear answers, and we knew that providing that was vital, given the potential harm from misinformation. So how did we do that? We synthesized many forms of insight to stay informed and to stay current. We listened to the public through our heart helpline, through surveys and analyses of online search terms. We engage with healthcare professionals, our researchers, the NHS, other charities, government. Our BHF intelligence team analyzed official health-related statistics weekly. We systematically reviewed research results by screening journals, scientific hubs, even Twitter feeds. Many of you actively tell us about the research you are about to publish. 13 months on, BHF have reviewed over 1,000 research publications to ensure that we are accurate and informed. Why? Because these insights help us to ensure the BHF Coronavirus Hub provides accurate evidence-based content for people affected by heart and circulatory disease. The hub features over 60 pages and is the most popular content on our website. We also recognize people were not able to access routine care and devised digital tools to help, with hubs to support self-management for managing blood pressure, weight, mental health, and to support cardiac rehabilitation. There have been 250,000 views of the cardiac rehab online video. And with the Coronas Hub, we have made a difference to millions of people. This week, we can celebrate reaching 6.1 million users and 8.3 million unique web page views. The Coronavirus Hub content is deemed as good quality. It's linked to by organizations, including the NHS, and 90% of our users feel more able to cope because of it. There are many comments that we regularly receive that are positive. Just to take one example, thanks to BHF, I don't feel alone in this uncertain time. But as the nation's heart charity, we also have a duty to speak up, to highlight the impact of the pandemic on routine care. And the statistics are startling. Fewer people sought help. We saw that with the heart attacks. There was a 50% reduction in presentation to A&E with symptoms that could be a heart attack. And people surveyed with health conditions told us that they weren't seeking help. On top of this, there is reduced access to specialist cardiac care. In the first year of the pandemic, there were 37% fewer GP referrals and a third fewer new cardiology treatment pathways were started. There's reduced delivery of diagnostic tests and treatments. Nearly a third fewer echocardiograms, heart ultrasounds, were performed. This has a domino effect. Without the echo or cardiac CT or cardiac MRI test, how do I know if you have heart disease or if your heart disease has progressed and you need to join the waiting list for treatment? And when it comes to treatment, BHF analyses showed there were 130,000 fewer heart procedures delivered. And this does matter. This matters because we've also seen over 5,800 excess deaths, so increased deaths from the expected number from cardiovascular cause. COVID-19 contributed to some, but it appears the excess deaths are at least part driven by reduced access to healthcare. And this backlog is growing. We see before the pandemic, only around 28 people waited a whole year for their heart procedure. So that includes things like stents or even heart surgery. This number has become 180 times greater. There are now over 5,000 people who've waited for more than a year. Heart surgery isn't a luxury. The window of opportunity to avoid lost lives or debilitating heart failure may be lost. And inevitably, with disruption at this scale, lives are at risk. So what are we doing? We're working hard to explain that. The current waiting time is just the tip of the iceberg. As you've now seen, there are people who haven't even been evaluated yet. Early diagnosis and prevention are the cornerstone of reducing the need. An estimated 470,000 fewer heart medications were prescribed. Undiagnosed or inadequately treated risk factors like hypertension and lack of optimization of heart failure medications are missed opportunities to prevent heart attack and stroke and to delay worsening heart failure down the line. Reduced research will reduce discovery of new treatments for the world's biggest killer, still heart and circulatory disease. This disruption at every stage of the journey could have impacts for years to come and may risk us going backwards, let alone stalling the pace of progress in terms of cardiovascular outcomes. And that's why we launched a campaign about the backlog of care. We've been speaking up on behalf of heart patients in the media and across the nations. Over 1,000 media articles have reached 70% of UK adults. Our media and communications teams have helped get heart disease care onto the agenda, into the public eye and onto the government agenda. And we also work really hard behind the scenes. We have submitted evidence to the Coronavirus All-Party Parliamentary Group, the Commons Health and Social Care Select Committee, the Lords Science and Technology Select Committee, and MPs have been raising questions about the backlog to ministers. And something can be done. It will involve a clear plan and long-term investment. Innovations in delivery of care catalyzed by the pandemic are part of the solution, so long as they do not exacerbate inequality, but alone are not enough. It needs long-term, year-on-year investment committed to now to enable planning, including to grow the workforce. We can build back better, but also bigger and fairer. BHF will present policy recommendations this summer for meeting cardiovascular care needs after this biggest challenge in the 72-year history of the NHS. But what have we achieved so far? We've saved lives by empowering people to seek help when they were sick. We are supporting millions of people with the answers to their questions. We're speaking up for the access to cardiovascular care people need. And we have never stopped powering science that could save lives one day. Thank you. Thank you to everyone that has helped us stay informed, to help us to inform others, and helped us influence to save and improve lives.
Sonya, thank you very much for that. Some very sobering statistics of the workload facing us in the health system, but also some very inspiring data as to what the BHF has been able to do in the acute crisis to support patients. I think this leads us on rather nicely to our next speaker, and that is Professor Keith Channon of the University of Oxford. The BHF developed with the NIHR a cardiovascular partnership to take forward a portfolio of research projects specifically related to coronavirus and cardiovascular disease. Keith chairs that partnership and is best placed to review that work. Keith, over to you.
Thank you very much indeed, Kent, and thank you, ladies and gentlemen, for the opportunity to illustrate how the BHF's clinical research effort has continued during the COVID-19 pandemic. And through leveraging the BHF strengths and the BHF family that Charmaine spoke about, the family of researchers, but also our patients, we were able to respond to the pandemic in a very constructive and very positive way in our clinical research efforts. As Kent mentions, this in fact relates back to the setting up of the NIHR, the National Institute for Health Research, British Heart Foundation research framework based on the partnership that we established at the beginning of the last period when the NIHR Biomedical Research Centres went through their funding round almost 5 years ago. Nilesh Samani and I had the idea that it would be very constructive for UK cardiovascular science to bring together the infrastructure and the assets of both the NIHR Biomedical Research Centres and the BHF centres around the country to engender greater collaboration, to address major unmet needs at scale, to help coordinate and leverage funding, and to better catalyse the translation of the most promising research into benefit for our patients. And so we established between these centres a partnership made up of all of the BRCs, the clinical research facilities, and the BHF centres, and brought them together in a partnership in which all of those aspects of the infrastructure participated. So we brought together their leaders, and we established a very active and energetic collaboration. And indeed, that maps geographically across most of the nations of the UK, shown on this map here. Many of the BHF centres are in fact in the same places as the major biomedical research centres with cardiovascular themes. We also included the NIHR CRFs, and we brought those assets, that infrastructure together to work in close partnership, to share ideas, to join together in research initiatives, to make the most out of the investment that had been made by the NIHR and the BHF. And so by the end of 2019, we had established this partnership. We already had several work packages for overarching collaborative research effort that had been prioritized by the partnership. And we were therefore very well placed in early 2020 to use and to build on the partnership's work to then address the challenge of the COVID-19 pandemic. Nilesh and I worked closely together with our colleagues across the partnership. We leveraged the BHF CRC capabilities, and we established a COVID-19 research framework to ensure that in the cardiovascular community, addressing the challenge of COVID-19 and cardiovascular disease that Sonya's told us about, we sought to avoid duplication, maximize impact, and ensure that our research was fully coordinated, had the best chance of leveraging external funding, and that we used existing assets such as large-scale data collection and access to those data in the major centres throughout the UK. You can read more details about these cardiovascular disease flagship projects, but just a word on how we did that. Every week during the pandemic, about 20 to 25 of the leaders from across our BHF centres and NIHR centres met by Zoom to look at the proposals that had been submitted in that previous week. We undertook peer review extremely rapidly over the weekend. We gave feedback to applicants. And from that process, we, within days to weeks, established 7 BHF NIHR flagship projects, which we then supported and provided a platform to leverage external funding, and also to make sure that individual centres got behind these research efforts in terms of promoting the importance of the research question and helping to recruit patients to those clinical studies. Here's a summary slide showing the 7 flagship projects. You're going to hear some about them later on in the programme and in the panel discussion. So I won't go through them in individual detail. Suffice to say that they are based around 3 broad areas that represent, I believe, the UK's principal strengths and assets in cardiovascular science, clinical cardiovascular science. They were based very much on imaging, using both CT scanning and cardiovascular MRI to characterize and understand the complications of COVID-19. And that ranged from cardiac imaging to multi-system and multi-organ imaging using MRI, to a specific focus on the pulmonary vascular complications. Second, the flagship projects were based on the enormous strengths that we have in the UK in using routinely collected healthcare data to understand the impact of disease again underpinned by the BHF Data Science Centre, led by Cathie Sudlow, who will be on the panel later. And also taking advantage of the UK's large existing patient cohorts and feeding data from those cohorts through to understand large-scale gene variants that you'll hear more about in one of the talks, and other aspects of how COVID-19 impacts on cardiovascular disease pathogenesis and future risk. Critically, we were able to take advantage of the BHF's PPI network that Sonya has already spoken about to involve patients in our rapid decision making and in how we run these flagship projects. And these projects have already helped us to understand, for example, why individuals with cardiovascular disease are at higher risk of adverse outcomes during COVID-19. What are the specific effects of COVID-19 on the cardiovascular system? How do we calibrate those in the broader context of the pathogenesis of cardiovascular disease and the impact, of course, of any severe illness on cardiovascular risk? And then look at how the COVID-19 pandemic has impacted on the care of patients who have cardiovascular disease. These flagship projects have already proved to be extremely scientifically productive in terms of publication and impact. And here are just 2 or 3 slides before I finish, showing how, for example, very rapidly the BHF Data Science Centre, leading the Cardiovascular Disease COVID UK consortium, were able to publish insights into COVID-19 on data records at unprecedented scale. This is 90% of the whole UK population. It's pretty much 100% of the English population, 54 million people in a data resource. COVID-19 catalyzed the ability to take advantage of data assets in a way that we had not foreseen. And it was only possible to take advantage of that new opportunity by the BHF's prior investment in its Data Science Centre and the coordination that the BHF NIHR Cardiovascular Partnership brought to that opportunity. In the area of understanding underlying biological mechanisms, we've already seen some of the early genetic and biological results, and you'll hear more about those data in an upcoming talk later this afternoon. And we're starting to see evidence of how COVID-19 infection impacts on not just the heart through the COVID heart study led by John Greenwood, but also led by Stefan Neubauer and colleagues on how MRI reveals other changes in many different organ systems of the body. And finally, not yet fully published, but we're seeing more papers coming through in the archive server about how the clinical presentation and the clinical course and outcome of COVID-19 relates to the presence and nature of underlying cardiovascular diseases present in those patients. We're contributing in the UK through the BHF NIHR partnership to international studies that give the UK a major profile and have enabled us to make critical contributions to those international studies. This is just the first few papers to show how crucial this partnership and the work of the BHF has been with the NIHR centres across all of our centres to impact on research in COVID-19 and cardiovascular disease. I'll finish by just thanking not all of the people by name on this slide, but to reflect how critical it is for the BHF to work in close partnership with other research organisations such as the NIHR, with the BCS, and all of the centres that illustrate how the BHF family that Charmaine spoke about at the beginning of the afternoon is crucial, not just for fundraising and for profile, but it's the research family of the BHF interacting with the NIHR and other research organisations that enables the BHF to respond quickly and powerfully to a major challenge, but also a huge opportunity to learn more about cardiovascular disease and how to improve treatments for our patients. Thank you.
Thank you, Keith. That was an excellent overview of what is clearly a very exciting programme of work which will deliver over the coming months and years. You've covered a lot of ground, and all three speakers have kept beautifully to time. We don't have a Q&A session now, but if any in the audience do have questions they'd like to raise, use the Q&A function of Zoom, and those questions will be available for the Q&A session that follows later on in the programme. Now, for the next session, I will hand over the chair to Professor Nilesh Somani, the Medical Director of the BHF, and he's going to introduce our guest speakers. Over to you, Nilesh.
Thank you very much, Kent. Good afternoon, everybody, and my welcome to this meeting. What we'll do in this session, as Kent alluded to, is that we'll dig a little bit deeper into the three questions that Keith posed that were really part of the flagship projects. The first one being, why indeed are people with cardiovascular disease at increased risk, and why that may be? So that's a really important question for our patients. The second is, what are the complications? What are the specific things that COVID-19 does to the heart and circulatory system? We knew right from the very early on that it's just not a disease of the respiratory system or the lungs, it's the effect of the heart and other circulatory organs. And we'll explore that both in the short and long term. And the third is the ongoing question of the impact of COVID-19 on routine cardiovascular care. So those are the three really important exam questions we felt that needed to be answered in relation to cardiovascular health and COVID. So we have three great speakers for this. Kent already alluded to them. To start off with the first of those questions, why are people with cardiovascular disease at increased risk? We are joined by Professor Aroon Hingorani, who is Director of the UCL Cardiovascular Department, and is also Director of the BHF's Excellent Award at UCL. So welcome, Aroon, to the meeting.
Thank you, Nilesh, for the introduction, and good afternoon, everyone. So I've been asked to try and help provide some insight on the question, why are individuals with cardiovascular disease at higher risk of COVID-19 with severe outcomes? So the management of the coronavirus pandemic has centered on public health measures to reduce viral transmission, on the rapid identification of safe and effective medicines to treat COVID-19 through the recovery platform and other efforts, and on the development, evaluation, and dissemination of effective vaccines to provide protection through immunity. But from early on in the pandemic, a key question for the public, for patients, and for scientists has been, why do some individuals, but not others, develop COVID-19 and severe outcomes? So it soon became clear that patients with cardiovascular disease, as well as those with certain cardiovascular risk factors, were overrepresented among people who were diagnosed with COVID-19, who were hospitalized with COVID-19, who were admitted to intensive care units, and among those who unfortunately succumbed to their illness. So understanding the explanation for this association was and continues to be important. If real, regardless of any direction of cause and effect, this relationship has important implications for risk prediction and targeting public health and other measures. If also causal, it might point to interventions that might reduce the risk of COVID-19 and severe outcome, but also increase biological understanding of the pathogenesis of COVID-19 and a legacy of knowledge on the pathogenesis of cardiovascular disease more generally. But understanding the reasons for associations between a risk factor like cardiovascular disease and an outcome like COVID-19 and severity can be challenging. Aside from a direct cause and effect link, a risk factor and an outcome can become associated because they share a common cause without one necessarily directly causing the other. For example, the association between LDL cholesterol and coronary heart disease was eventually shown to be causal as a result of genetic studies and randomized trials of LDL-lowering drugs such as statins and PCSK9 inhibitors. Well, one irrefutable feature of the pandemic is that age is a key risk factor for COVID-19. So the upper panel on the right-hand side in this slide compares 16-week age and specific fatality rates for COVID-19, which are the dots, red for men and blue for women, with the correspondingly scaled age and sex-specific hazards for non-COVID death, which are the dotted lines, indicating a doubling in risk for every 5 years or so of increasing age. Now, age is also a very important risk factor for cardiovascular diseases and other chronic conditions. So the lower panels are taken from an analysis of age-specific incidence of 308 conditions in the NHS from nearly 4 million linked electronic health records. So one potential important explanation for the association between cardiovascular disease and COVID-19 and its severity is likely to be age as a common causal factor. So this recognition has had two actionable impacts. First, it's been able to inform on which sectors of the population should be advised to shield during periods of high viral transmission. And secondly, it's provided a tool with which to prioritize the sequence of vaccination so as to protect those who are most vulnerable first. In addition to age, it's also become apparent that certain cardiovascular disease risk factors, for example, obesity and diabetes, also increase the risk of COVID-19 related mortality and could form another category or subset of common causes for the two conditions. Now, we know from genetic studies and trials that obesity and diabetes are causal risk factors for cardiovascular disease. Recently, data from the Open Safely platform, which has linked information from 20 million people registered in primary care to 11,000 COVID-19 related deaths, has shown a steep relationship between body mass index and indices of diabetic control and COVID-19 mortality. So could this link be causal? Well, this is an example of work from one of the BHF NIHR flagship projects. It's from Alice Carter, Deborah Lawler, and colleagues at Bristol, who are uncovering evidence that elevated body mass index may be causally related to COVID-19 based on genetic evidence employing the Mendelian randomization paradigm shown on the left panel. Importantly, as I'll discuss later, this relationship appears to be robust to COVID-19 severity and selection criteria for case and control subjects, and is a specific effect of BMI on COVID-19 and not vice versa. Resolving this common cause concept in more detail and considering possible molecular mediators, there's much emerging basic science evidence, which is summarized, for example, in this review article from Peter Carmelier's group, that the molecular pathogenesis of COVID-19 involves dysregulation of metabolism, inflammation, endothelial dysfunction, and coagulation pathways that are the very same pathways that BHF funding has supported research in over many years, and which are now implicated in the pathogenesis of atherosclerosis and vascular diseases. We know clinically that patients with severe COVID have derangements of these pathways and are also at higher risk of certain thrombotic and inflammation-related cardiovascular events, which will be covered in later talks. So further evidence of the potential causal relevance of these molecular pathways comes from the emerging genome-wide association studies of COVID-19, in which genes known to influence several inflammatory and prothrombotic processes have been implicated in the risk and severity of COVID-19. So the upper panel shows findings from the latest report of the Genomic Consortium on over 2,000 critically ill patients with COVID-19 from 208 UK intensive care units, with UK Biobank participants serving as controls. And the lower panel shows finding from the International Host Genetics Initiative and the Million Veteran Program in the United States, using over 7,000 patients hospitalized with COVID-19 and over 1 million controls. So genetic approaches to identify molecular causes that might be shared between cardiovascular disease and coronavirus disease are also being extended to identify drug targets in the human host rather than the virus that might interfere with viral entry, with replication, or in the maladaptive host response, applying the principle of Mendelian randomization again, but this time to test drug targets rather than risk factors. So a particular interest of this work is motivated by the successful model of the recovery trial to use genetic evidence to help inform drug repurposing opportunities. So as an illustration of how discovery and data sharing can rapidly catalyze progress, the curation of host proteins interacting with the SARS coronavirus 2 during its replication cycle in vitro, as well as circulating proteins altered during coronavirus infection, shown in the left lower panel, led to the identification of genetic variants influencing the level of those proteins in the right lower panel, and then the application of these variants as genetic instruments to enable evaluation of their causal relevance in coronavirus infection in the top right panel, and where these are druggable to identify new therapeutic targets. So returning to explanations for the link between cardiovascular disease and COVID-19 risk and severity was the possibility raised early on in the pandemic that certain widely used treatments for cardiovascular disease might alter the risk of COVID-19 and its outcomes. And one reason for this speculation was the viral entry mechanism exploits the angiotensin converting enzyme 2, whose expression was thought to potentially be altered by ACE inhibitor drugs, which are widely used by patients with cardiovascular disease. However, these concerns were rapidly allayed both on the basis of mechanistic arguments as well as empirical evidence from large linked electronic health record data and prescribing data sets, which showed that there was no increased risk of COVID-19 from ACE inhibitor or angiotensin receptor blocker use. And these findings enabled advice to be given to patients with cardiovascular disease to continue their routine medications, helping to avoid harms that might have otherwise occurred due to medication withdrawal. So in much of the discussion so far, I've focused on potential common causes for cardiovascular disease and COVID-19. But it's important to be aware of, to diagnose, and if possible to correct for, a form of bias in this type of research that induces a spurious association between a risk factor and an outcome. And this has been referred to as collider bias. It refers to a spurious association between a risk factor and an outcome, induced when both the risk factor and the outcome influence some other variable, the collider. And when researchers then restrict analysis on the basis of the collider variable. So for example, a spurious association between cardiovascular disease and COVID-19 might be induced when this relationship is evaluated only among people who are hospitalized or admitted to intensive care, or who use a symptom tracker app, since both cardiovascular disease and COVID-19 might independently influence the likelihood of hospitalization, ICU admission, or app usage. And an excellent discussion of this is provided in the reference shown. An important related source of bias can arise depending on the availability of data and or on the way in which COVID-19 cases and controls are selected for evaluation in studies. For example, individuals from the population as the basic denominator might be exposed to coronavirus or not, become infected or not, symptomatic or not, be hospitalized or not, and become severely ill or not. And which of these groups is chosen as a case or control can influence or bias certain risk factor associations. And another bias that may be induced is the availability or accessibility to testing for coronavirus. So in recognition of this, it's been important to establish studies where the sampling frame, the denominator, is the general population rather than convenient samples. And thankfully, the UK, through the efforts of the BHF, HDR UK, and many others, has shown itself to be well placed to achieve this. So one of the ways has been through linkage of electronic health record data between primary care, secondary care, and COVID-19 related data collections. And this has been achieved by the Open Safely initiative, but also more recently, as Keith Channon recently mentioned, through the NHS Digital Trusted Research Environment, developed through the efforts of the BHF National Data Science Centre, via HDR UK and one of the BHF NIHR flagship projects, the CVD COVID Consortium. And this links records from over 50 million people. And another has been to use the existing longitudinal cohort studies with rich pre-pandemic research measures that can be linked to relevant COVID-19 and other health outcomes. So in addition to the important role of UK Biobank, two new important initiatives are the COVID-19 National Health and Wellbeing Studies, established by the Chief Science Advisor of the government to enable better understanding of health, social, and economic impacts of COVID-19. And another is the BHF NIHR flagship project, the Covidity Cohort Network, from which I showed two exemplar findings earlier. So I'll conclude by saying that individuals with cardiovascular disease may be at higher risk of COVID-19 and severe outcomes because the two conditions share certain common causes. Research to date on the nature of this association has helped inform guidance and policy for patients with cardiovascular disease and those with cardiovascular risk factors, and also for patients receiving cardiovascular-related medications. And emerging insights on cause, potential treatment targets, refined estimates of risk, and the legacy of future knowledge of broader relevance to the understanding and management of cardiovascular disease are likely to emerge from this very substantial effort in research that's been focused on managing the COVID-19 pandemic. Thank you.
Thank you very much, Aroon, for that excellent distillation of a range of complex interactions between cardiovascular disease and COVID-19. And I'm sure we'll come back to those during the discussion. I'm sure there'll be some questions about this, but thank you again. What we'll now move on to is the second of the presentations, which really is to look at the impact of COVID-19 on the cardiovascular system. So even in healthy people, as you know, there is evidence emerging that COVID-19 affects the cardiovascular system. And to discuss this, we've got Professor Marc Dweck, who is the BHF Senior Research Fellow at the University of Edinburgh. Welcome, Marc, and look forward to your presentation.
Okay, so thank you very much, Nilesh, for the kind so I'll just crack on. Great. So my remit today is to discuss how COVID-19 affects the cardiovascular system, both in the short term and the long term. So to start off, I'd ask you, if you can bear it, to cast your minds back to early 2020. So the first wave of COVID-19 was hitting the UK. Hospital admissions were going up, the ITUs were filling up, and patients were dying. Yet we really didn't know very much about how this virus worked. As we've heard, early reports showed us that patients with cardiovascular disease and cardiovascular risk factors were at increased risk for COVID-19, but we really didn't understand how or why. And it raised some important questions. So is the heart also involved in COVID-19? Is it more than just the respiratory disease? If so, how? And is that important in determining how patients do when they contract the illness? So in principle, cardiovascular imaging is very well placed to answer these questions. We now have a range of very powerful imaging techniques that can take pictures of the heart and give us detailed information about its structure, about its function, and even about disease activity that is occurring in the body. And so here we have a tool or tools that we can use to improve our understanding of the cardiac effects of COVID-19. However, imaging during a pandemic is challenging. And there are two major concerns. The first, certainly in the first wave, was about the consumption of PPE. Obviously, this was in very high demand, and we didn't want to waste it on research scans when it could be used on the front line. And the second was the risk of spreading the virus, both to patients, but also to the imagers. And this was very much at the forefront of our minds with the death of our friend and colleague, Professor Galderisi, who unfortunately died during the first pandemic in Italy. So how do we proceed? Well, what we wanted to do initially was to try and capture as quickly as possible a picture of how COVID was affecting the heart. And to do that, we contacted our colleagues and friends throughout the world and asked them to tell us what they were seeing when they were doing echo scans on patients hospitalized with COVID-19. So we designed a smartphone app to collect this data, and the response was really tremendous. In just 3 weeks, we had data from over 1,200 patients with COVID-19 from across 69 countries and all the major continents. And what did we find? Well, this is really the headline finding. And essentially what we saw was that in half of these scans done on patients with severe COVID-19 infections, we saw there was some abnormality of the heart. And this was a mixture of problems with the left side of the heart, with the right side of the heart, and also with the lining of the heart that encases it. And in 1 in 7 of these patients, these abnormalities were severe in nature and therefore likely to affect the patient's outcomes and long-term prognosis. So a key question when you look at this, and when we thought about this, and this actually recurs through most of the studies, is how many of these abnormalities are due to COVID-19 itself, and how many are due to the patient's comorbidities and other cardiovascular conditions. And so we did an analysis where we excluded any patient who had any history of cardiovascular disease. And the findings were broadly unchanged. About half of patients had an abnormal echocardiogram, and in about 1 in 8 patients, we saw severe cardiac disease. So this showed us, I think for the first time, that COVID-19 does affect the heart, and it's a disease that can affect the cardiovascular system as well as the respiratory system. So my colleagues from Mount Sinai Hospital did another study. This time they looked at a slightly smaller population, 190 patients who again had severe COVID-19, and this time had an elevation in a cardiac biomarker, troponin. And they saw that actually 2/3 of these patients had abnormalities on their echo scan with a pretty similar set of findings. So problems with the left ventricle, problems with the right ventricle, and problems with the lining of the heart. But what was actually most important about their study was that for the first time they showed that if you had these abnormalities on your echo scan, you were at nearly a 4-fold risk of dying during your hospital admission. And so not only does COVID-19 affect the heart, but it also appears important in how patients do when they have the disease. So these studies on acute patients and acute COVID, I think, established the effects of COVID-19 on the heart. But like all good science, they raised as many questions as they answered. And I think in particular, they raised these 3 questions. So what about milder forms of COVID-19? Does that also affect the heart? Is the damage that we observed reversible? And actually, what is the mechanism for this damage? Why are patients getting cardiac damage when they have COVID-19 infection? And over the last year, BHF investigators have been investigating these questions and really leading the way in our understanding of the cardiovascular effects of this virus. So we'll start with the first question. Does COVID-19 in its mild form affect the heart? And this was a study performed by Professor Moon at Barts. He looked at 75 healthcare workers who had had just mild COVID-19, and he compared them to 75 people who had similar risk factors but hadn't had COVID-19. And he did very advanced, sophisticated imaging of the heart using MRI, which gives us very detailed pictures of the structure and the function of the heart. And he was not able to demonstrate any differences between these 2 groups. So it doesn't look like COVID-19 results in long-term structural or functional problems with the heart, which I guess is good news and reassuring. What about if you do MRI scans in people with severe disease? Well, this was the first study, and it's fair to say it caused controversy, particularly this headline finding, which was that 4/5 of patients that had recovered from COVID-19 had evidence of cardiac structural or functional abnormalities on their MRI scan. Now, this caused a lot of anxiety and worry. In the US, our friends there were even considering pausing competitive sport at one stage. But actually, once you get into the data behind that headline, it's a bit more reassuring. So the first thing is that the cardiac function in these patients was basically normal. So it looks like the dysfunction that was observed in that acute phase goes back to normal in the majority of these people. And secondly, the majority of these abnormalities that they described, the 78%, were pretty minor structural alterations that might easily be explained by their comorbidities rather than the COVID-19 infection itself. So to the rescue came Professor Fontana, another BHF researcher from London, and she did a study of 150 patients who were imaged a month following severe COVID-19 infection. And again, she showed that cardiac function was normal in these patients. So it looks like a lot of that dysfunction that was seen on the echo studies goes back to normal. And also she showed that many of the more subtle changes, these T1 mapping, T2 mapping changes, were probably related to patients' comorbidities, because you saw very similar findings in a group of patients who didn't have COVID, but had similar cardiovascular comorbidities. However, she did show that around 40% of patients do have areas of scarring in their heart muscle following COVID-19. And in particular, this had two patterns. One, a pattern of myocarditis, usually due to myocardial heart muscle inflammation, and the second due to myocardial infarction, heart attacks. So how do we put this all together? What's our current understanding? Well, in patients with severe COVID-19 who are hospitalized, these people have increased inflammation and a prothrombotic state that can lead to myocarditis and myocardial infarction respectively. That's an important mechanism for the damage that we have seen in the acute phase. But also they get lung disease, they get respiratory failure and hypoxia. Now that can lead to myocardial ischemia, again causing cardiac damage, but can also lead to problems with the right ventricle and the right ventricular issues that we saw early on with echocardiography. So these are probably the major mechanisms leading to myocardial dysfunction in COVID-19 in the acute phase. But the good news is that most of these LV and RV dysfunction problems that we saw in the acute phase go back to normal in the chronic phase. However, we do see some residual scarring in around 40% of patients. Two things that we really need to understand better are the role of inflammation and this prothrombotic state and how this influences the cardiovascular manifestations of the disease. And there are BHF-funded studies looking at this question. My team with Professor Newby are looking at a tracer in Edinburgh where we are directly imaging fresh thrombus formation. You can see the yellow and red areas are areas of new thrombus, and you can see that causing large pulmonary emboli, small pulmonary emboli, but also microemboli in the lung parenchyma. And of course, we can see evidence of thrombus formation in the cardiovascular system, in the coronary arteries, and also in the left ventricle. And then other groups are looking at inflammation in the cardiovascular system using FDG PET in the myocardium and in the arteries, but also using novel CT techniques that can tell us about inflammation based on simple CT scans. So I think this will further improve our understanding of the cardiovascular effects of COVID-19 and importantly, the mechanisms underlying this. So in conclusion, in terms of the imaging, I think we've learned that mild COVID-19 probably doesn't cause much in the way of structural or functional cardiac problems. However, in acute severe COVID-19, heart dysfunction, both of the left and right ventricles, appears pretty common. And when it's there, is associated with poor in-hospital outcomes. In the long term, this dysfunction appears to largely reverse. However, around 40% of severe COVID-19 patients have residual scarring, and we need to better understand the mechanisms underlying that. Is that due to comorbidities? Is that due to COVID-19? And what are the functional consequences? And there's a BHF NIHR study underway called COVID Heart that will further investigate these problems. However, more broadly, I think we've learned quite a lot from COVID-19 in a general sense. And the first thing is that the power of national and international collaboration. When we all work together, we can really find out a lot about diseases very rapidly, and of course, develop new treatments and ways of improving prognosis. When it comes to imaging, the BHF and its researchers have been at the forefront of developing our understanding of how COVID-19 affects the heart. And I think that reflects the world-leading imaging infrastructure and expertise that we've established in the UK. There's still a lot for us to learn, a lot for us to find out, but it's worth just remembering that we're now just over a year after the start of COVID-19. We understand more about how it affects the heart than we do about flu. And so this has really been a success story in improving our understanding of this new disease. Thank you very much.
Thank you very much, Marc, for a really excellent presentation. I'm sure I can already see some questions in the chat box for you, so I'll come back to those a little bit later. Just to encourage people to put their questions into the chat box, and one of my colleagues, Christian Norris, will try and synthesize them so we can answer some specific questions that you raised. Okay, we'll have enough time during the rest of the meeting to discuss some questions from the audience. So really now the sort of trilogy of the discussion in this session, which is around a topic that Sonya had already started discussing around the impact of COVID-19 on the routine care of patients with cardiovascular diseases and what we learned about that. I really wanted to welcome Professor Barbara Casadei, BHF Professor of Cardiovascular Medicine at the University of Oxford, who led some of the very early studies trying to understand this particular impact. So welcome, Barbara, to the meeting, and we look forward to hearing from you.
Seeing whether I can progress my slide. So far, damage caused by the now we have
Barbara, you're coming in and out for me, and I suspect you might be for others as well. Now I can see you now, so that's good. Why don't you kick off again, okay?
I was just saying that so far we by the COVID-19 pandemic, about 2 million estimate the impact on the pandemic, because unfortunately there is more the collateral damage of the economy and as well.
Barbara, shall we just pause for a second? So apologies to interrupt your talk, but I don't know whether Kelly or Maria can tell me, is there a problem with Barbara's audio? So just to ask, just Barbara, just pause for a second, because there's a little bit of difficulty hearing you at the moment. That's better. You want to have a go again now, okay?
Yeah. Can you hear me?
It's still a little bit fragmented for me, for sure. But if you turn your video off as you have, maybe it'll be better.
It seems to be working on my end, but okay. Now?
Yeah, please go ahead now. Apologies.
Okay, so I was on the of an epidemic or has already been well other smaller diseases, and the one of Ebola, where you could see this the reduction in both can be extremely damaging, and in this case it has been estimated that maternal perinatal field as a result are the reasons for that quite familiar. I still have a problem the slides, I'm afraid. No.
Kelly Maria, do you think we have lost Barbara at the moment?
Hi, Nilesh. I think we have lost Barbara, so it might be best for us to move to the Q&A for now.
Okay, great. Thank you. I hope she can come back and we can hear her. We've got until 3:20 for this session, so I hope Barbara can come in and discuss. But shall we move to the Q&A at this stage, Christy? And why don't we, the team, bring up all the people who've spoken so far to join us? Okay, so just highlight everybody to come through. Okay. There's always going to be a glitch on Zoom calls, as well as you know, but we'll bring Barbara back in. As soon as she's back in, can people let me know so I can make sure that she's welcome back. Okay, look, we have a kind of sort of flood of questions coming in for colleagues, and I won't sort of take them in any dramatic order, but it would be good to. So Charmaine, the first one really is for you. It's about when you anticipate that the BHF income will recover back to pre-pandemic levels.
Oh, good question. I'm not surprised from the community that we fund, that's come up, and of course is at the very centre of our thinking as a BHF. In short, we anticipate it'll be several years before we get back to historic levels, 2019-20 levels of funding. But please rest assured, as a BHF team, we're really focused on doing that. And we'll need your support in our fundraising and our advocacy more than ever to make that happen. And we're not giving up on the call to government for funding to help mitigate the drop for us and others. So please trust us that we're going to keep going as hard as we can to mitigate the impact that we have. Thanks, Nilesh.
No, thank you very much, Charmaine. Keith, a question for you about the NIHR-BHF partnership, and really a lot of sort of support for this from in the chat. It's about additional ideas inspired by the COVID-19 work about what the partnership may do. I know that the partnership was already in existence and was already doing some great stuff. But I think, given that the partnership flagship process we developed, are there other things, are there other inspired projects that the partnership could achieve together in the future?
Thank you, Nilesh. I think there are probably three components that I would highlight in my answer to that. The first is that the COVID-19 pandemic and our response in the area of clinical research illustrates what partnership research at scale can achieve and how quickly it can achieve those things. So I think the first lesson is that we should seek to work together across organizations, across institutions, and across geographies, and we can achieve so much more as a nation with the help of the British Heart Foundation, and we should do that not just in COVID-19. The second is that if we work together and we work collectively, we can take greater advantage of what I think the strengths of UK cardiovascular science and cardiovascular research assets are, and they've been writ large so far, and we're going to hear more about them. And that's areas like imaging, it's patient cohorts, it's access to routinely collected clinical data, and critically, and I think this has come out, it's the enthusiasm that our patients have in the UK for supporting research and for participating in research. And I think that's a really important factor. And thirdly, of course, and Charmaine spoke about money, but if we're going to leverage funding at a national and indeed international level, then by working collaboratively, and this is something the partnership has learned, we're much more successful in leveraging strategic level funding for heart and circulatory disease research. And that's been perhaps the third lesson that's come out of the partnership.
Can I add to one of that? I think that's the terrific answer, but I just wanted to add, and others might want to chip in as well. I think one of the other things the partnership does, and we're looking at this from a global perspective as well, is about rarer disease, or the Cinderella conditions, if I can put it like that. There are a number of them which haven't received as much attention from the research community as one would have wanted. I mean, you and I have talked about myocarditis or pericarditis, as a disease where there hasn't been the same level of interest. And I think the partnership could allow the sort of collaboration to develop in areas where which have been underdeveloped in some ways.
Yes, and maybe just a very brief response to that, Nilesh, which I agree with, is of course cross-disciplinary research. Yeah. It's the British Heart Foundation. We're interested in heart and circulatory diseases, but we have so much to learn from other disciplines of biomedical research that we're not aware yet are relevant to heart and circulatory diseases. But by forming those collaborations, we look back and realize we have a lot to learn by fostering cross-disciplinary research collaboration.
Thank you. Aroon, a question to you. Somebody asked about the connections between genetics and COVID-19 health outcomes. What do we know now? I presume the question may also be really connected some way to ethnicity issue. What's the current thinking about genetics and COVID-19 health outcomes?
Yeah, thanks, Nilesh. So I think what genetics is helping us do is to understand what the causal mechanisms might be for severe COVID disease, which aspects of normal physiology, metabolism, and so on are dysregulated, and which of those mechanisms might be targetable therapeutically. And I think one of the themes that's emerging is that those pathways may be pathways that are shared across multiple conditions, including multiple cardiovascular conditions and other risk factors for cardiovascular disease. And I think this is sort of in line with our emerging thinking as a sort of biomedical research community, that we should be focusing a little bit more on multimorbidity, not considering diseases in isolation, but considering the co-occurrence of related conditions in individual patients and how we might optimize the management of conditions in tandem with one another. And I think one of the things that's been exposed in the coronavirus pandemic is that some of the treatments that we already have might be used more widely than they currently are. They may be effective in more than one condition. And I think where genetics can play a part is to help understand which medicines might be used more broadly than they currently are. In relation to the second question about particular ethnic and ancestral groups, it's widely recognized in genomic research internationally that individuals from non-European populations are less well represented in those types of studies. And that's clearly an area that we need to address better. There are many international research efforts now underway that will enable us to compare and contrast different predisposing factors in people of different ethnicities and ancestries in order to understand better how we might optimize the use of drugs and other treatments in those groups. That's terrific. I think the bit about treatment, I think, is the most powerful. I think we'll learn about new treatments because we understand sort of the causal links, particularly for severe disease. I think that's where some of them. Marc, a couple of related questions for you has come. You mentioned something that we learned more about COVID-19 and heart disease in the last year than we had know about flu. If we said, maybe that was the interpretation. So the question is really around whether the way COVID-19 affects the heart and the circulatory system is different from these other viruses. Or we've known a lot about influenza and the winter epidemics and how those cause a spike in heart-related deaths. Do you think COVID-19 has a sort of different mechanism or is more severe? What's your thought on that compared to other viruses?
Yeah, I mean, that's an important question we've been asking ourselves. And, that means you have to go back to the literature and see how much we understand about imaging findings in influenza. And it's pretty sparse as what we found. And certainly nothing compared to the data we have for COVID-19. I suspect that if you did the echo studies in patients hospitalized with influenza, you would see a high proportion of LV and right ventricular dysfunction in the same way as you see for COVID-19, particularly if they've got bad respiratory disease. We need more studies to tease that out better. I think one thing that is probably different is the prothrombotic effects of COVID-19. That's not something that generally we associate with influenza and seems to be an important part of the pathogenesis of COVID-19. So, we need more information about COVID-19, but we also need more information about influenza to really answer that, I think.
I think the thrombotic effect is really very, I think it is specific, in the very early days, the risk of pulmonary embolism until we learned how to give everybody anticoagulants, and also the risk of small MIs, troponin rise MIs, where it's affecting small vessels, became very obvious, didn't it, really very early on. I think we learned how to treat those.
Yeah, and it was interesting when we were doing those PET studies, these are largely in patients we didn't really suspect of having thrombotic complications, but actually when you try and image it with a very sensitive marker, you see it in a lot of these patients. So yeah, I think it is an important part of the pathogenesis.
But one great message from your talk, which I wanted to colleagues take away, is that whilst there's still a lot more work to be done about longer-term effects of COVID-19, particularly in the fibrosis that you showed that some people might be affected with, it's good that we don't see lasting damage in terms of the cardiac function of those who recover. So that's really good news.
I think that's a relief. I think we were all worried we might have a kind of big surge of patients coming to us with heart failure following their infections. But, this initial data, MRI data, shows that basically the cardiac function goes back to normal, even though there is quite a lot in the way of scarring if you look hard enough in the muscle. So I don't think we're going to see a lot in the way of heart failure down the line, but we do need to understand what the long-term effects of that scarring is. And there may be some, other effects that come to light down the line.
Great, Barbara, welcome back. Okay, what I'm going to do is to allow people to listen to your presentation. We got to 20 past, so I'll stop the questions in about 3 or 4 minutes, and then you can have the last 10 minutes for your presentation, if that's okay, before we take a break. So there's still a lot of questions here, which I'm only going to be able to cover a few of them. Charmaine, coming back to you, there's a question about how do we galvanize the fact that public are interested in science as a consequence of this. Even I say this for all people, my mum is interested in science now than she was before. How do we galvanize that into greater support for the BHF and for research?
Yeah, my mum too, Nilesh, so we share that. Do you know, I think clearly it's just been so incredible to hear the science being discussed today, but I think science and health are at the forefront of our minds and the general public's minds more than ever. And that's important not only to inspire support for the work that you, our BHF family, in the way that we've touched on today, but also to help people in making healthy choices. So we are giving that thought in terms of, as we refocus as an organisation on our research core, how we communicate that and how we tell our story, and the story of the amazing scientists, including those you've heard today, to inspire more support. So a great question, and something we're actively working on. Thanks, Nilesh.
Okay, let me open up a last question, really, open to all of you before we ask Barbara, and maybe just go around. We've talked a lot about negatives over the last hour or so. Maybe negatives in one. I mean, there's a lot of great things that BHF have done over the last years as a research community, but what can we take away that are positives out of what's happened? So just a sort of question, to each of you around, is there anything positive coming out of this crisis and the pandemic, which will be a good legacy for us? Just so people are, thinking about this. I'll ask Barbara, why don't I start with you?
Me, I would say data sharing. I think that the opening up the access to data has been a revolution, and has actually showed us what we can do when that access is present in real time. Yeah. We can't go back from that.
No, I think we'll be discussing that, Barbara, during the panel discussion as well, where Cathie Sudlow will be, this sort of how do we capitalize on the legacy of the sharing that's happened and not let it sort of drift backwards. I thought that all 6 of you would have the same answer on data sharing, so I'll see what other questions people come with. Aroon, do you have a view on what's positive come out of this?
I think one of the most notable things has been the pace at which new research discoveries have been shared. And research builds on prior research. And if we don't get research findings out in a timely fashion, we progress slower. And I think one of the questions that we'll all need to address as a community and more broadly is what are the optimal ways of sharing new research findings? While speaking to ensuring that they are high quality and accurate, but at the same time ensuring that they're not delayed. And I think that's a challenge, but I think we need to grasp it and deal with it.
Great. I'll keep it open now for the other three. Does anybody else want to share anything? Keith?
I think the pandemic has illustrated to us, Nilesh, that investment in high quality infrastructure and assets pays back dividends. And therefore we should continue to invest in high quality, highly curated, excellent resources, assets. And those assets are, of course, people who can respond. And they're also the physical and data assets that we should be so proud of in the UK. And if we manage those in a collective, collaborative manner, then we can turn those very powerful resources towards a new challenge whenever it arises.
That's some really great examples that all of you demonstrated today, and we'll hear from Cathie as well about the Data Science Center a little bit later. Colleagues, just again to thank all of you for your contribution. I want, if you had another very bright, positive, shout out now, but otherwise what we'll do is give Barbara her 10 minutes for her presentation. Barbara, apologies for the...
Try again.
Here you are, okay?
Thank you very much. So where were we? So what I was saying is that the damage of the pandemic, the 2 million deaths that have been recently reported by the worldwide are a fraction of the impact on the pandemic on health. And that is because there are several layers, 4 layers, in fact, of indirect damage that such an event can cause. And that is related to health, collateral damage on health, on other diseases, on the economy, and on the geopolitical view of the world. And I still can't advance my slide. Here we go. This is what I just said. That's encouraging. So, and I was saying that this is a phenomenon that has been well documented for other infectious epidemics and for the Ebola crisis in particular, where there has been a problem both in the availability of healthcare and the uptake of healthcare, and that has caused many more deaths than the infectious disease itself, and in 25,000 only in the maternal perinatal health at that time due to that. And and here are the reasons why that has happened that unfortunately are now quite familiar to us as well. There has been obviously an excess deaths. This is during the first and second wave of the SARS-CoV-2 infections in Europe and in the world. And not all of this excess deaths has been due to COVID-19. You can see particularly in countries where the infection was very localized to region where it completely overwhelmed the health system, and particularly the region Lombardia of Italy here, that more than 40% of the excess deaths recorded were actually not due to COVID, but to the impact of COVID on the collapse of the health system. In the UK, the situation has been better, but we still have excess deaths not due to COVID, as shown here, per 100,000 inhabitants and in absolute terms. And the reason, however, are different, because the health system at that time, particularly with the exception perhaps of London, was not overwhelmed, but we have a reduction in the uptake of health. And this is shown here. For instance, these are data from CPRD, recording both the contact of patients to general practice and the general practitioner recording hospital admissions. And you can see that there is essentially a 50% reduction in the contacts due to major cardiovascular events such as stroke, heart failure, myocardial infarction, that by the time it was July, it was still only partially recovered. In a survey that was launched by the European Society of Cardiology at that time over 5 continents, you could see that there is a remarkable consistent perception of a reduction in patients coming to hospital with ST elevation myocardial infarction. About 80% of the responders said, yes, there is a significant reduction. And of those who reported a reduction, they said it was greater than 40%. Not only that, but the patients coming into hospital during this time came in late. And we know that time is brain, is myocardium, and therefore it's particularly worrying seeing these figures saying, yes, 62% said, yes, they do present later than usual, the patients who actually make it to the hospital, and 50% of them are admitted beyond the optimal window for PCI or thrombolysis. So here we have, the heart attack of the 70s, if you like, coming back during the pandemic. But of course, surveys can exaggerate, data can be biased, and so it is particularly important to measure these trends very accurately if we want then to respond to them in an adequate fashion. And for that, we started a collaboration with NHS Digital, which for me was a revelation, to have actually access to this data, 147 acute hospitals across England in near real time, looking at this central depository of data to understand really the scale, the nature, and the duration of this change in admission for different type of acute coronary syndrome during the outbreak, and also to evaluate whether in-hospital management of patients with acute coronary syndromes had been affected by COVID. And I'm pleased to say you now that it wasn't, that once the patient made it to the hospital, they were really dealt with very well and very rapidly, as we are normally doing. So, when we looked at these trends, we saw this pretty dramatic reduction in the admission starting at the beginning of March. At that time, there was a lot of speculation as to why this reduction in admission with patients with a heart attack, what could be the reason? And it was even had been postulated that it may even be real. That is, that there is less heart attacks out there because people are in lockdown, they have a less stressful life, there is less pollution and all of that. But actually, if there is something that we know about infectious diseases and flu in particular, as we were talking before, is that it does increase the incidence of acute coronary syndrome. Infectious diseases do, influenza is thought to increase the incidence of acute coronary syndrome by 2-fold, for instance. And so, that didn't seem very likely. And if we look at this data more carefully, we actually see that this is not the case. Why is not? Because the reduction in the admissions actually starts before lockdown, so pollution and all of that cannot be the reason. And it starts with the first COVID-19 deaths reported in the UK and the message, stay home, protect the NHS, and the fear that starts to come into our nation, essentially. And in fact, if the Public Health England ran a number of serial questionnaires to the population and really documented that about 50% of the responders said that they did not seek advice for a worsening of a health condition during the pandemic. And the main reason for that was to avoid putting pressure on the NHS, as you can see here, but also for fear of contagion and other reasons. But you stay home, protect the NHS really worked even when it shouldn't have in this respect. Another example of, if you like, the irrational nature of of this reduction in admission is shown here, where you see the reduction in various regions of England, and with the exception of London, which is the one that shows the steeper reduction, there is really no connection between the prevalence of the infection and the reduction in acute coronary syndrome. For instance, the West Midland here in purple and the Southwest, who had amongst the highest and the lowest prevalence of COVID, have the same rate of reduction in acute coronary syndrome over that time. On the contrary, the Northeast, which is a highly affected area, you could see that the reduction is somewhat flatter. So it doesn't really, it's not because the health system is overwhelmed in a particular region by COVID that this has actually happened. So, at that time, I was the president of the European Society of Cardiology. We got to know about these trends from Italy earlier on. And so on the 21st of March, I wrote a letter to all national cardiac society in Europe, to the British Heart Foundation and the British Cardiovascular Society, to actually start a campaign to counteract this reduction. And the strap line was, we need to continue to save the lives we know how to save. And for acute coronary syndrome, this is definitely the case. And you have seen from the data that Sonya showed before and Charmaine, what amazing response the British Heart Foundation has been able to really put out to the population together with the British Cardiovascular Society. And it's nice, again, through access to this data, to see what impact, you've seen this picture before, it actually had on the recovering. These patients started to come back to the hospital, despite the fact that by the beginning of April, the COVID-19 was still raging in England and in the United Kingdom. So it is very pleasing to know that although, we've estimated that about 5,000 fewer patients with acute coronary syndrome in England missed out treatment and probably also secondary prevention at the start of the COVID-19 outbreak, that this campaign has been able to reverse these trends. And what it is also important in that this has happened, as I said, all over Europe. And, in the countries where they had the ability to follow the trend, this is in Italy, for instance, you can see that is almost the same picture. And again, I think that it is very pleasing to see. So what impact all of this had on patients with cardiovascular disease? At this point, it is difficult to know the burden of morbidity, what is going to happen to these patients who had the heart attack at home, as I said, as in the 70s, without really taking advantage of all we can do now with patients with heart attack. And but we do have data on deaths. And we know, for instance, in other countries, in France in particular, that there was an excess of cardiac arrest outside the hospital over this time. And we have data for England. Here you can see that if you look at total cardiovascular deaths in hospital at the time of COVID, we have a reduction as shown here, but we have obviously an increase in cardiovascular death in patients with COVID admitted to hospital that are mostly due to pulmonary embolism. We're talking about the thrombotic complications before. But what it is important is that there has been more than a 30% increase in deaths at home, beside those in care home. And most in agreement with the data that I've just shown you, these are not due to COVID, which is out here. They are cardiovascular deaths due to acute coronary syndrome of patients who did not go to hospital. So, the message that Sonya really put forward this morning is incredibly important public health message for the whole population. So in summary, I would say that the indirect impact of the COVID-19 pandemic on patients with cardiovascular disease in the UK and worldwide has been significant, and now we know better, we know how to prevent it. In the UK, the main reason was not the overwhelming of the health, the NHS, but it was the desire to reduce the pressure on the NHS and the fear of contagion. They were the main reason why people did not come into hospital, even with pathologies as severe as a heart attack or a stroke or heart failure. As I said, there was a 40% reduction in hospital admission for acute coronary syndrome by the end of March 2020, meaning that there was about 5,000 patients in England that missed out on life-saving hospital treatment at the start of the COVID-19 outbreak. And the consequences of this will become more obvious as time goes on. But, again, ending on a positive, I would say that, the impact of the BHF campaign in the UK, the European Society of Cardiology campaign in Europe, really highlights the importance of collecting and of having access to real-time health data. And that's to trigger intervention timely and to guide policy making, even in the absence of an emergency. And that, I think, will be repeated many times today, because I think is a very, very important lesson we mustn't forget. And here I want to thank the people and the structures, the infrastructures that were involved in this study, and particularly Oxford Leeds Axis, NHS Digital, the British Heart Foundation, of course, the British Cardiovascular Society, and the ESC, and also Simon Ray and Sonya and Nilesh for really taking this on and going forward with it. Thank you very much.
Thank you very much, Barbara, for your great presentation. We won't have time for questions because we got to move on very rapidly to the CMO's presentation. So those of you who need a break, you got 4 minutes according to my timetable. So I suggest that those of you who got strong bladders, stay, or don't need a cup of tea, stay, and we'll join. The CMO will be joining us in about 4 minutes. Okay. So Barbara, again, thank you so much. We couldn't take all the questions, and we'll take them during the next session when we have a panel discussion. So we'll try and answer other questions during that period. But thank you, everybody, and see you again in about 3 minutes with the CMO's presentation. Kent, back to you in a moment. Thank you very much, Kent. I hope colleagues enjoyed having Chris Whitty with us for the last session. I'm sure lots of questions were not completely answered, but great job, Kent. Thank you. So the next session really is a panel discussion, and I hope that we can have a very interactive session on this one with questions from the audience. We got 5 outstanding colleagues who have joined us, distinguished colleagues who are joining us for this session, and you can see that on the slide here. So I'll just briefly introduce them. Professor Chris Brightling, who is Professor of Respiratory Medicine in Leicester, and also the Principal Investigator of the FOSS COVID-19 project, which is looking at the long-term effects of COVID in the UK. Professor Patrick, welcome Chris, Professor Patrick Chinnery, who is Clinical Director of the Medical Research Council, but also chairs the initiative which looks at new treatments for COVID-19. Chris Whitty mentioned that apart from vaccines, we also think interesting about new treatments. So Patrick, welcome, and I'm sure you'll tell us about that issue. Professor Nick Linker, who is the National Clinical Director for Heart Disease at NHS England and NHS Improvement. Nick, I'm sure we should talk about how, the impact of how we manage the challenge that COVID-19 has placed on cardiovascular care in the UK. So welcome Nick. Professor Cathie Sudlow, Director of BHF Data Science Centre and also Professor of Neurology in Edinburgh. Cathie, I'll ask you the same question I asked Chris Whitty about how we protect the data legacy going forward in a minute, but I'm sure you'll tell us about the Data Science Centre. And finally, Professor Andrew Pollard from the University of Oxford, who is in the Department of Paediatrics, infection immunity there. But of course, I know many of you know Andrew from his work on the AZ vaccine. So welcome, Andrew, and thank you for joining us. Okay. So the way we're going to run this session is really to give each of the panelists about 3 or 4 minutes to give us a little insight into the questions I've just posed, starting with Chris and working through, but then to really make it very interactive in terms of questions. So please give us questions for the panelists to take forward. So Chris, to kick off with you, to just discuss your feeling about, we haven't really touched on long COVID very much. We talked a little bit about the cardiovascular consequences of going long term, but really wanted to give your impression of how long COVID is going to play out.
Thanks very much for the invitation today, and I've really enjoyed listening to the sessions. So long COVID is this constellation of symptoms that people have after a COVID-19 infection. And it was very early on in the pandemic when we realized that in addition to the clear need for prevention and acute treatment, that there was quite likely going to be a number of people that would suffer with persistent symptoms after they had an infection. So we started a study called FOST-COVID, which was focusing on people who'd been hospitalized, partly because they were the people that had tests initially, so we knew they had COVID-19, and also because we made an assumption that that would be the group where they would have the greatest problems in terms of long-term symptoms. And what we recognized is that this would be a multidisciplinary problem, that it would affect many organs, and that we'd need to study at scale. So we set up a study that then was across all 4 nations, initially in 50 sites, but now in the last couple of weeks been increased to 80 centers. We formed a working group structure that then included a number of different organ specialties, as well as cross-cutting areas such as looking at ethnicity and health and immunology. We have a cardiac, a metabolic, and a pulmonary vascular working group, and we included representation from patients, but also importantly, representation from charities at a very early stage. And I was absolutely delighted that the British Heart Foundation has then been a part of FOST-COVID and working very closely with patients in each of those working groups. So we had 3 aims, and our aims are really very straightforward. We first of all wanted to know what's the size of the problem of long COVID and what's its severity. Secondly, are there current treatments that we've given acutely that might actually already modify the way long COVID occurs? And thirdly, could we then also, once we made early discoveries, then pivot towards more deeper dive studies, but also then to intervention so we can then start to change the trajectory. The design is looking at patients at an early visit around about 6 months and then 12 months, and it's an in-clinic for 3,000 individuals, so really very detailed three-hour visit, plus a larger number of 7,000 that will also then have more online assessments with data linkage, as you've raised to the CMO as being an important part of this. I'll just very briefly give some early findings. So one of the early findings was linked into the Seymour study, which is now aligned to FOST-COVID and is a BHF flagship, which is looking at MRI imaging and identified a number of abnormalities in multiple organs. And I think that's a really important study that we've extended and expanded into more centers. And we also asked the question, how many people still had persistent symptoms at 5 to 6 months? And that was 70%. So 70% of people still have persistent symptoms. And those that are most risk are those of middle age, slightly different in the acute setting. So it's between the ages of 40 and 65, predominantly in women rather than in men as it is in the acute setting. And comorbidities, so 2 or more comorbidities, with cardiovascular disease being the commonest comorbidity. So what's next? It's to look at the trajectory. We're now studying the 1-year follow-up, and data will be coming out soon. To unpick mechanisms, we have very large bioresource as well as the imaging and the linkage that I've mentioned. And also to reach out globally as well, that we have now established links across Europe and with North America to really try and then understand and make a difference to patients who are suffering with long COVID.
Thank you very much for that. I'm sure there'll be lots of questions. I already got some in my own head, but I will come back a bit later. So to move on to Patrick, I think, Patrick, welcome to the meeting. This challenge, if you wish to accept it, is tell us about the new antivirals or other drugs apart from vaccines that you think are really going to be promising for us in the months to come.
Yeah, thank you very much for the invitation, Nilesh. Well, I mean, as you've heard, developing treatments is important, important for the acute illness and important for the newly described long COVID that Chris and others are informing us about. I mean, the reason why treatments are important is because not everyone responds to vaccines. And if we look across the world, it's unlikely for the short to medium term that everyone in the world will be protected by vaccines, and new variants may emerge. So we clearly need to develop new treatments. It's interesting, I was at a workshop convened by Patrick Valentin a month or so ago about pandemic preparedness in advance of the G7 summit. And it's clear that the rest of the world sees the UK as leading the way in terms of therapeutics. And the three things I'd briefly like to touch on is, why is it that we've been leaders in the world? What have we learned about trials that we need to hang on to for the future? What treatments have we discovered in the last year, and what's on the horizon? So to turn to the first topic, there have been plenty of ideas. As you mentioned, I was asked to set up a panel to prioritise candidates into the national studies for COVID. And we've been showered with suggestions, from very sensible ones to completely crazy ones like goat's milk. And of course, a priori, you don't know which ones are going to be effective and which ones aren't. And so I think people approach the idea with some passion and often some bias as to which treatments work. So we're not devoid of ideas. Challenge, of course, is showing which ones work and which ones don't work during a pandemic when there's a lockdown and the NHS is under considerable strain. Everyone wants to solve the problem. And so we saw a profusion of trials globally. The best example, of course, is hydroxychloroquine. You know, there were 167 trials registered globally to study hydroxychloroquine. 50 actually are still open, despite the fact that we had a definitive result on it 6 months ago, showing that it doesn't work. And actually, if you look at the United States, there are around 100 trials for COVID running at the moment, both academic and commercial ones. Most of them will only plan to recruit a few hundred participants, and most of them actually even aren't going to read out in 2021, probably in early 2022, depending on how much illness there is there. So what we saw is this profusion of activity, which has led to a lack of results coming through. And I think what we managed to do in the UK through our national infrastructure that Chris Whitty was just describing, is to have a coordinated national effort embedded in our NHS, and particularly to have an impartial way of identifying which treatments we're going to trial in the government-funded platforms, which span the whole spectrum, from new medicines in early phase to big phase 3 studies in the community and in hospitals, such as the recovery platform that you heard about, which has actually just checked today, has recruited just short of 40,000 participants. And actually, by embedding them in the NHS, it means that when the new treatments are discovered, they're adopted very quickly, which is another challenge, of course, in therapeutic developments. So what works? Well, not much is the honest answer to the question. The first effective treatment was an intravenous antiviral called remdesivir, shown in a commercial study that was published in June to be effective. And in truth, all it does is shorten the illness in severe cases by about 10%. So it's certainly not a panacea. The strongest treatment effect is from this drug dexamethasone, a commonly used drug across the whole of medicine, across the whole of the world. It's cheap, it's been around for decades. And it was shown in the recovery platform to reduce deaths in severe cases, people who required oxygen, by about 30%. So a very impressive response. And then a few months later, additional evidence for some antibodies that tackle cytokines. These are chemical messengers that we produce in response to inflammatory stress, anti-IL-6 cytokines, and which by using those drugs, it's been shown to reduce mortality by a further 4%. These have become the standard of care. And the most recent result was from the community study Principle, where an interim analysis provides the hint that inhaled budesonide might actually shorten the illness in pre-hospital patients. But you can see, if that's the full story, there's an enormous amount to do. We've learned an awful lot about what doesn't work rather than what does. That, of course, is important, because we now know to avoid those medicines and avoid their side effects and focus on recruiting participants into trials to find new medicines. So what's next? Very briefly. Well, there are several trials still in flight. Obviously, the recruitment in these studies has gone through the floor in the last 6 weeks, as we've seen on the national news. But there are some that will read out soon. We'll get a readout for aspirin in recovery very shortly. Another drug called baricitinib will read out probably in the early autumn, and there are several other drugs in flight. But I think more importantly, from the work that several people on the call have done, we're learning about the mechanisms, and we're learning about what treatments we might use in future trials, and particularly when in the disease course we might use them. We've also set up some prophylaxis studies in care homes and in vulnerable groups, patients with renal transplant, for example, to see if certain medicines work in that context. And building on Chris Brightling's work and others, there are some long COVID studies that have been set up and also are under consideration at the moment by NIHR. And then finally, of course, you'll all have heard about the antiviral task force that was launched a few weeks ago to identify 2 new oral antivirals for early COVID before Christmas. And there are some very promising candidates actually that look as though they'll be effective. So to conclude, in the next 6 months, I think we'll see more readouts. I think particularly in the early stages of the illness where we really had no effective treatments to date with new antivirals. And I think we'll also see a more personalised approach to treating COVID based upon our understanding of the illness as it evolves. So we use the right treatments in the right people. Thank you.
That's great. Thank you very much. It sounds encouraging. So I'm sure the audience will want to pick that up. Okay, we'll have plenty of time for discussion, but we just bring Nick Linker in now. Nick, welcome again to the meeting. Nick, the question that I posed for you was, of course, you're very familiar with the impact that COVID-19 has had on cardiovascular care. What are the plans for the NHS to do the recovery of this? And of course, COVID also taught us a lot about new ways of treating people with heart disease, video calls and so on. So your perspective on how things might change in the future.
Thanks very much for that, Nilesh, and thank you for asking me to talk this afternoon. I think you're absolutely right. The one thing we noticed from very early on in the first wave was the impact of COVID on cardiovascular care. We noticed, as you know, the decrease in emergency presentations of people with heart attacks, with heart failure. We also noticed the increase in mortality and more severity in terms of disease presentation. The one thing that was very positive from early on was the improved collaboration within the NHS. So from the start of the first wave, we set up regional calls with the various cardiologists, cardiac surgeons, with the administrations in the NHS regions. And out of this came a desire from the regions to go back to some extent, and to improve in other extents the way of working together, in that there was a great desire to re-establish cardiac networks as a means of improving the delivery of cardiac care. So there's a slide which we'll just show, which shows the aims and ambitions of the cardiac networks going forward. So in line with the long-term plan ambitions, we are planning to improve the healthcare for patients, reduce CVD mortality, particularly focus on prevention and proactive care. If you hit the button to go down, please. Yeah, thank you. So what we are doing is we are establishing a whole pathway approach to the management of patients with heart disease. We are looking at CVD prevention. We are involving primary care as a key element of the pathway approach. We are not just restricting ourselves to secondary and tertiary care, but the whole pathway from detection through treatment to rehabilitation. And once more, please, with the slide. Thank you. The other thing that clinicians will be aware of is that there are a number of programs already in place around cardiac disease. The long-term plan, getting it right first time, specialized commissioning, outpatient transformation, etc. And the plan that we are already planning is that all these goals and all these programs will be delivered through a single approach. There will be clear, standardized end-to-end pathways. particularly in relation to prevention, heart failure, valve disease, and chest pain. But as you can see, the 4 pillars there, we will be improving the prevention with early and accurate diagnosis, improving the recovery across the board. This has all been approved by the NHS, and it has been funded with recurring funding, which is really important. If you think about the way we have developed this program, this was only came together as a concept at the end of last year. So around November, December time, we have already got the funding. The funding has been distributed to the regions. The regions are currently in the process of setting up 13 cardiac networks around the country. So the NHS, as Chris Whitty referred to in his talk, at times we can move quickly. And in 4 months, we have gone to delivering a whole new way of providing care for the patients within England. The last point I will make is, as you'll see at the very bottom of that slide, it talks about managing heart failure at home. So as Nilesh had mentioned, one of the things that we have also taken on board with this is the improved delivery of digital technology to support patients at home in terms of helping them to manage their conditions, to particularly manage blood pressure, for example, manage heart failure, and the use of increased digital technology to enhance outpatient appointments through advice and guidance. So we've had some problems in cardiovascular disease with the impact of COVID, but we have also learned some lessons about better ways of delivering cardiovascular care and different ways and innovative ways of doing this. Thank you, Nilesh.
Nick, thank you. Well, thank you very much for that. Before bringing Cathie in, I just wanted to make a plug for something we're going to do. Your slide reminded me of this, because this possibility of new digital solutions and using advanced analytics to support people outside the hospital, the BHF are just about to launch a new competition called the Cardiac Catalyst Fund, which is to challenge people in the NHS, particularly in academic health centers, to come up with suggestions of how that sort of digital transformation and AI might help to improve the care of people with cardiovascular disease. So we very much look forward to working in partnership with you, because if we find that there are things that work, then we obviously want them implemented or at least taken forward. So we want to really stimulate the community to think about that particularly with COVID-19, there are clearly going to be people who have seen new things that work, and we want to test it out properly. Okay. So we'll come back. Cathie, welcome as well again, and really just about obviously the role that the BHF Data Science Center has played in the pandemic, and where you see things going forward with this.
Yeah, thanks very much, Nilesh. So it's really thanks to the vision and generosity of the British Heart Foundation that the BHF Data Science Centre was established in January of last year, 2020. And we're embedded in Health Data Research UK, which is the UK's Institute for Health Data Science, with the goal of improving the public's cardiovascular health through improving access to and use of data at scale for cardiovascular health data science. So at the beginning of the pandemic, which we were, along with everyone else, plunged rapidly into, having just got going, we knew 3 important things from a data point of view. So we knew that there were long-standing difficulties with access to population-wide data for research to benefit public health. And that was particularly the case in England, where NHS Digital, the major provider of those data to the research community, although it's not NHS Digital's main job, of course, it's got a lot of other jobs. But as that major provider, NHS Digital didn't have a secure research environment to hold and link those data and make them available to researchers. They relied on data dissemination, and they were very cautious about disseminating data because of the security and privacy challenges. Secondly, there was a particular need for the research community to be able to access and link healthcare data together with primary care data. So hospital data and death data and various other data sets had been reasonably widely available, but rarely primary care data. Thirdly, we knew there was an essential need to understand the impact of cardiovascular disease on COVID and the impact of COVID on cardiovascular disease. And so using cardiovascular disease and COVID as a motivating and driving exemplar and working in partnership with NHS Digital we sought to try and plug some of those major gaps, particularly with a focus on England, to create, in partnership with NHS Digital, a new trusted research environment to hold and link healthcare data. And we set up a consortium that's open and inclusive to enable researchers, large numbers of researchers around the country, to access those data and work jointly together to solve some of these difficult issues. And you've heard a little bit about that resource that we created jointly with NHS Digital earlier on in the afternoon, which is now enabling researchers from over 40 institutions, NHS and academic, across the UK, with a membership of over 180 people in the consortium and more than 50 analysts now working together on data to address issues. So this resource holds together primary care data, which was so much needed, secondary care data, data about deaths, and data about COVID, both COVID lab testing data and more recently information on COVID-19 vaccinations, and some specialist cardiovascular data sets as well, all linked together across the entire population of England. It's very important because it covers the whole population. So it means that research in very underrepresented groups is enabled. It also allows statistically powerful research. And perhaps one of the best examples of the research that it's enabling right now, where you need a very large population to chase down very rare events, is looking at the rare clotting events that have been implicated in association with COVID-19 vaccination. Now, we know that these are very rare, and therefore it's important not to overemphasize their risk in comparison to the known major benefits of vaccination, but understanding how and who they affect and what that excess risk is requires a very large population. And we're feeding back information as we develop this research program to the MHRA and other policymakers in the UK. So I think there are some legacies of these developments. So access to data at unprecedented scale and breadth, which will help research into the longer term consequences of COVID, but also research into a whole range of other areas beyond. It's helping people to collaborate together. It's providing a platform to link other data sets to routine healthcare data for trials, for cohorts, for imaging studies, for linkage to wearables and apps and so on, all of which I think form part of the long-term ambition of the BHF Data Science Centre. And in particular, I think it's been a great enabler of team science.
Great, Cathie, thank you very much. And I'm sure I've already seen some questions in the chat that I'll need to come back to. Andrew, welcome. Even a pediatrician is welcome to the BHF Annual Conference, just to say that. Never mind the respiratory physician we got in Chris, so we are very tolerant here. Anyway, welcome to this, and really thank you for joining us. Congratulations on all the tremendous work you've done in developing the AstraZeneca vaccine, and really to get your perspective on, Chris Whitty touched, I don't know whether you were at the time when you were able to join his session, but he touched about what vaccine might do, but just to get your perspective on what's next for vaccines.
Thank you very much, and thanks for inviting me. As you say, it's with some trepidation that I speak to not only grown-up doctors, but heart specialists. I guess just first of all, looking back, I think it is an incredible success story when you consider that on the 23rd of April last year, so just almost exactly 13 months ago, the first needle was stuck in a volunteer here in Oxford. And today there's 450 million doses that have been distributed worldwide to 172 countries. So I think it shows what you can do when government, industry, academia, and the public get together behind a program like this. I think for me, in some ways, one of the most important things has actually been the university's commitment to the not-for-profit distribution of the vaccine, which was only possible because AstraZeneca, a big pharma company, agreed that that was the right thing to do in a pandemic. And as a result of that, 98% of the vaccines distributed through COVAX to the low-income and middle-income countries around the world are from at the AstraZeneca collaboration. So I think in some ways we can be enormously proud of the last year. But despite that, we've got this incredible inequity in the world. So when you say what's coming next, we've got to solve this inequity where if you look at high-income countries, somewhere around 60 to 70% of them now have vaccinated those 20% of the population who are at risk of dying. So we know that it's the over 50s, those with other health conditions who are likely to die from COVID. Rich countries have done that. But if you look at low-income countries, there is not a single low-income country which has achieved that 20% target. So despite all of those efforts, and of course one vaccine developer can't cover the whole world, but we're so far away from that. And it's really distressing actually to, at this moment where we're talking in many high-income countries now about vaccinating 20-year-olds and then children who have incredibly low risk of severe disease. That in many countries there are people who we know will die in the next month and not getting doses. So I think that's perhaps the first thing of what happens next. We've got to resolve the inequity. And that's partly a supply question, but it's also a question about the global politics and the redistribution to try to do them. I think Chris made this point really well, that if we don't do that, we're going to become a greater risk of new variants emerging because they emerge wherever the virus replicates at a high rate in populations where the disease is uncontrolled. As far as the other part, which was around what happens next, I think Chris is right. We actually don't know. I mean, he was presenting a perspective on what happens if immunity wanes. What about new variants that threaten the immunity that's developed from vaccines? And of course, we have to have those options on the table. But they are unknowns at the moment. The one thing that is certain is about viral evolution. And in vaccinated populations, this virus will survive. And the only way it can do that is by transmitting. So it will have to make mutations, as we've just seen with the B.1.617.2 variant that can transmit a bit better in vaccinated populations. The B.1.351 South African variant transmits well in both vaccinated and in naturally immune populations. And of course, that is giving us a hint at the future. The future will be living with this virus, new mutants, and we'll lose track of the names of them. They're complicated enough at the moment. We're going to lose track of the names, and there'll be so many over the next few years. And our surveillance system is going to pick them up, and they'll be spreading in the population who are vaccinated. Most people are going to have mild infections with them. And the question is, are we going to have breakthrough cases at a level that means there's an ongoing public health crisis? Or is it going to be something like flu or less than flu, which is still pretty awful, but it is manageable within health systems around the world? And we just don't know the answer to that question. I suspect that this increasing transmission of B.1.617.2 is going to give us huge insight into that. Because if we keep most people out of hospital over the next few months who have been vaccinated, I think that's going to give us a real clue about what the future looks like. And I'm a bit optimistic about it because we all get infected with coronaviruses as children. And throughout our adult life, we do keep getting those coronaviruses, but they just cause respiratory tract infections. Immunity is incomplete to coronaviruses. They mutate, they're going to continue to spread. And I think we just, maybe it's over optimistic, but there are some data. The data from South Africa, from the trials where severe disease was an endpoint in the trials in South Africa, there was really high effectiveness of the vaccines against that endpoint, including almost complete prevention of death. So that really already gives us a cause for some optimism. And the animal studies show that you can get complete protection against lower respiratory infection, even with variants that spread and cause upper respiratory infection. So all of those are pointing to perhaps a hopeful outcome of the vaccine programs, that things will look better in the months ahead. But of course, we don't know for certain. And so we have to be prepared for booster doses. We know how to make new variant vaccines, and that can also be in the armory. But I think we also, apart from COVID, do need to think about other respiratory viruses. And in adult practice, influenza is the big one as a seasonal virus. And we've had no influenza last year. We really don't know which virus is going to circulate But there are predictions that once it does come back, it's going to come back with a bang, because immunity from flu does not last so long, and we're likely to have a lot more susceptible people in the population this year or next year when it does come back. And as a paediatrician, I'm much more worried about RSV, which causes between 25 and 30,000 hospitalizations in babies every year in the NHS. And those numbers really drive a lot of the use of paediatric beds in the winter, and they're absolutely full to capacity. This year, we'll have 2 years worth of young children who have never met the virus. So if we have no social distancing and everything opens up, the virus is still around, we are likely to have a big surge of RSV. And some of the studies have shown that a proportion of those adult respiratory admissions each year, probably almost as common as flu in some years, are RSV as well in the frail elderly. So I think we have a big threat from other respiratory viruses as well, if not this year, next year. And I think when you look at the RSV example in the Southern Hemisphere, it didn't come in the winter, which it has done ever since records began. It came in their summer when they were out of lockdown and caused a surge of disease. So it's the timing, which is normally predictable, is much less predictable in this setting where we've got non-immune populations. And then perhaps one last comment is just that we've got really exciting new technologies. And I think this means a new period in vaccination where we can deal with some of the diseases that have been really difficult. So the RNA vaccines, the viral vaccines and so on, they just allow us to have more options in the future for perhaps doing better against some of these viruses.
Great. And great, thank you very much for you giving that perspective. In fact, you answered one of the questions that had popped up in the chat, which is around the worry about flu this year, because as you say, that perhaps the last year there was hardly any flu, people commented on that, and the worry is whether we're going to see a double whammy this year. And I think I can see that you're concerned about that as well. So that's very helpful to get that perspective. We've got about maybe 5 minutes or 10 minutes or so for questions. So we'll just rattle through some of the ones we can cover. The first one, Chris, was to you, really. You mentioned the sort of gender difference, if I understood, or somebody asked a question about the gender difference in long COVID or the severity of long COVID symptoms, that's from your early learning. Do you know why that might be the case?
It's quite intriguing, and it's definitely contrary to what we see in the acute disease, so more common in women. Mm-hmm. And as I said, also in middle age. So that's raised questions about other conditions that also are more prevalent in that group, such as autoimmunity. And it also raises issues around sex hormones as well. So there's actually emerging data to show really quite considerable production of autoantibodies, and some of those are actually linked to the symptoms that we observe. So for example, we see very commonly skeletal muscle pain, and there is an increase in autoantibodies to skeletal muscle as well as to other organs. So that's a really important area, and I think that could also link into Patrick's point around interventions, that you could then imagine a precision medicine approach where you could identify a presentation that was consistent with an autoimmune driven disease, which could then have an intervention. And I'm not suggesting that's the whole story, but I think there's going to be a whole collection of different mechanisms that are driving the condition in different people.
I mean, there's been a question, just to follow that up with another, for long years we've grappled with this chronic fatigue syndrome. Patrick, I'm sure, knows a fair bit about that as well. It's something, and a lot of people describe the symptoms post-COVID in a very similar way, about excess tiredness, not being able to walk, breathless going upstairs, and so on. Do you feel that there is a similar, we learn about that disease as well as a consequence of the focus on long COVID?
I think we are. I mean, with long COVID, we largely know when the patient had the disease, certainly those who are hospitalized, and most of the time in those people who are managed in the community. We then know the virus that's causing it, whereas with chronic fatigue syndrome, ME, it's often a diagnosis of exclusion, and it may not be always clear the onset or the cause. So I think COVID-19 infection might actually shed some light on our understanding of CFS-ME, and we'll also probably find that a proportion, although I suspect it's probably the minority, have really exactly the same problem, but COVID-19 seems to be throwing up different symptoms, different presentation, and therefore likely different mechanisms to what we think is causing CFS.
That's very helpful. So a question that was actually asked to me, but I need to put it to the panelists rather than answer it. It's about inequalities, really, and highlighted the, obviously, it's become very clear through COVID-19 that these have existed and have exacerbated the effect of the pandemic. They're not going to disappear at the end of the pandemic. The question is about the leveling up agenda. What can we do? I mean, give us some thoughts as to what the BHF, Patrick, wearing your MRC hat, what can we do in terms of research around leveling up agenda?
So I suppose, Nilesh, thank you. I would come back with a response that actually, at least in terms of clinical trials, the activity has been very leveling up. So the recovery trial, as an example, and it does apply to the primary care trial too, effectively networked across the whole of the United Kingdom. And in fact, it wouldn't have been a success had it not been, and had it not had a strong presence in, non-teaching hospitals all over the country. And we actively monitored recruitment throughout the first wave of the pandemic, and the highest recruiting sites, with the exception of Leicester, of course, were district generals like South Tees Hospital or Chesterfield, places you wouldn't normally associate with research. And so I think, it demonstrates that we can both do the research across the whole country, across hard to reach groups, and implement the outcomes of those research findings through the same systems. It's not perfect. We've still got to do more work. But although COVID has exposed some of those inequalities, it's also shown us ways that we can address them.
Okay, no, terrific. Ellen Lowry, who asked the question, I hope we got some answer. There's all, we are focused on this, at the BHF as well, about how do we level up in terms of our research funding and where it goes. I think some of the things that Cathie at the Data Science Center are doing will help as well. The digital clinical trials will help, allow that to be disseminated more broadly. To do the trials where the disease burden is will help as well, I think, in this context. Cathie, did you want to come in on this?
Yeah, I mean, I agree with that, Nilesh, and I think it's not just about trials as well. It's about observational research studies, like the one that Chris is leading, or where one's researching across the entire population. The advantages of being able to link data sets in an inclusive manner that represent everybody by definition, because they include everybody, are potentially allow us to both shed light on the inequalities that we don't fully understand, but also start to derive some of the ways in which we can address those. It's very interesting what Chris Whitty's been telling us over the last few days about how one can map the geography of just about any disease, and it affects the same areas. So these inequalities are long-standing and entrenched, but I don't think that means we can ignore them. We absolutely have to address them and address the inclusiveness in research agenda.
Andrew, several questions for you, but I just pick one because of the time issue, really. What do you see? You may have tested some of this already, but the most significant learning regarding vaccine development during the pandemic, what do you think the most significant learning is?
Well, it's an almost impossible question to answer because there's so much. But I think if we look at it from the pandemic perspective, what could be done differently? And I think in some ways we've been incredibly lucky with this pandemic. I mean, I know that seems an odd thing to say with over 120,000 deaths in the UK, but we've been incredibly lucky because it's a virus that we knew a lot about. We knew the biology of it. We knew how to make vaccines using spike protein. We already had vaccines for other coronaviruses. And it's been relatively straightforward to design, manufacture, and then do the trials and get to this point with quite a lot of confidence. And rather than the normal 1 in 10 vaccines successful, we've had probably 5 or 6 out of 10 have been successful. And that's put us here at this point where 1.7 billion doses across all the developers have now been distributed. But I think one of the things for me that's actually pretty chilling about this is there are a lot of other viruses that could cause pandemics that we don't know anything about, and we're not prepared. So I think one of the things that perhaps we need to learn is that there needs to be now investment in a lot of that background work, whether it's the surveillance, the structural biology to understand the different antigens that you might then use as immunogens in a vaccine, and perhaps even going as far as some of the early phase trials to test out some of these hypotheses. But I think there's a lot more investment needed at that early stage, so that if we did face another pandemic, we can go quickly next time. I think the other thing which is, I think we've learned a lot about, and perhaps is needs further tightening up, is around vaccine safety. You can't find rare events in trials, and I think we've done incredibly well in the UK in the safety reporting, picking up the association with thrombosis and thrombocytopenia as a very rare event. And now there's, with the second dose of Pfizer vaccine, this myocarditis signal, which I think is really important to understand, particularly in young men, is being reported in both in the US and Israel. So the fact that we've got surveillance systems that can pick that up is really important, but it's not true in most of the world. And in a pandemic, you have to deliver vaccines across low-income countries and middle-income countries. And apart from the US, UK, and parts of Europe, we really don't have those systems. So we need to resolve that urgently, probably even for routine diseases, let alone pandemics.
Thank you very much. Okay, I think we were almost at time. I need to thank all of you for taking part in this session. Really great. We've covered not all the questions we received, but you've done a great job. So Kent, over to you to close the session, the meeting.
Thank you, Nilesh. I hope you can hear me. I don't think I've got my video yet. Yeah. Okay, I think we're there. Well, it's been a fascinating afternoon for me. It has really been intriguing to see so many different perspectives on cardiovascular disease in relation to the coronavirus infection. I'm very grateful to all the speakers. I think the quality of the presentations has been excellent, and the timekeeping has been immaculate. My watch says we are exactly where we ought to be, and considering that we've had so many speakers over several hours, that is no small achievement. I'd also like to thank the staff of the BHF, who have been working very hard behind the scenes to make this event happen in the first place, and secondly, to run it. We have not had much experience with Zoom webinars. It clearly is a technology with considerable potential for the types of meetings we like to hold, and it's been a learning curve for all of us. I particularly would like to thank Maria Sullivan, Kelly Robbins, Christy Norris, David Wilson-Moore, Leanne Grech, and Cecilia Pulley from NIHR for all the work that they've done over days and weeks to make this happen. So there will be a short survey for your feedback circulated after the meeting, and tell us what you thought of this event. It is novel in two ways. Firstly, we haven't had an annual conference in quite this format before, and we would like to know what you would consider to be a good topic for a future annual conference next year. And secondly, any suggestions relating to the use and potential of the webinar format. So if you could spare a few minutes to respond to that questionnaire, it would be very much appreciated. As part of our 60th birthday celebrations, which the BHF is passing through, we're hosting an event called 60 Years Young, a reception at this year's virtual British Cardiovascular Society Annual Conference on Monday, the 7th of June at 6 p.m. You can access this through the British Cardiovascular Society program, or if you're not registered for that annual conference, you can contact one of the team via the email address annualreception@bhf.org.uk, which I think is in the chat box, and they can arrange your access. So finally, thank you again for you as an audience participating in this conference. Thank you for those who submitted questions. I'm sorry we weren't able to do justice to all of them. They were very diverse and very numerous, and I hope that you found the meeting as a whole both interesting and enjoyable. And I look forward to seeing you again in relation to other British Heart Foundation business in the future. Thank you. Bye-bye.